and had no real interest in nutrition, had no real training in nutrition, didn't really care about it at all. And unfortunately, that's not atypical of most doctors. We don't get a lot of training. And that's just the way it is. We sort of have passed that off to dietitians and also to, Weight Watchers and Jenny Craig, that sort of thing. So doctors don't have any real interest in it, which is very strange, actually, because we all know that obesity and type 2 diabetes are actually huge, huge, huge parts of health. Almost every single disease or disease state is made worse by obesity. So it's strange that doctors don't have any real interest in weight loss. We think that the solution is actually right in front of our face, right? We think it's all about calories and eating fewer calories and you'll lose weight. Unfortunately, we've all advised that, and nobody ever loses weight. I think, like something like 99% of people really just don't lose any weight. And that's why doctors have no interest in it, because we give the advice to count your calories, eat 500 less calories, and it doesn't work. So that's about the limits of what we do. And so since the 1970s, obesity has gone up and up and up. And closely behind that, type 2 diabetes, since the 1980s and early 1990s, started going up and up and up. And type 2 diabetes is actually by far and away, the leading cause of kidney disease. So as a kidney specialist, it became sort of a bigger and bigger and bigger part of my professional practice. And I started to get very unhappy with what I was seeing, because I could see that we weren't making really any difference in the whole disease of type 2 diabetes. And so I was really introduced to the whole question of weight loss, not through weight loss, but through type 2 diabetes, which was my thing. There are several large studies looking at the way we treat type 2 diabetes, which is our treatment paradigm was mostly about giving more insulin to lower blood sugars. And of course, giving more insulin, exogenous insulin, to treat type 2 diabetes caused people to gain weight. Everybody knows that if you lose weight, your type 2 diabetes will get better. So here I was giving them a drug which made them gain weight. And they're like, whoa, what are you doing to me? And I really had no answer to that. And it really struck me as this sort of paradox, but I was the one prescribing the medication. So I really was unhappy about what I was doing. But that was medical wisdom. It still mostly is medical wisdom sort of 10 years later. Thinking about it as obesity as a sort of personal responsibility and not looking after yourself and you let yourself go. And I remember thinking, hey, this is very strange, because here I am, I'm giving this guy insulin and he's gaining weight. But fundamentally, he's not changed. He's not doing more or less exercise. He's not got more or less willpower, because there's this whole thing about, obesity is just a lack of willpower, sort of blame the victim, sort of. The major difference was I gave him a bunch of insulin and he gained weight. So it's like, how does that work? And so I remember thinking, this is weird, because it goes against everything that I sort of was taught about weight loss and weight gain. And it didn't make any sense. And it was really just in front of my face every single day, because I have patients every single day who are on insulin and they're all gaining weight. So that was when I really started to look back and say, okay, let's go back, because I'm not happy about this. And I know nothing about it. And I need to know about it, because that's my job. And I really have to think about weight loss, because that's a key part of people's health. And as a doctor, that's what my responsibility is. So that's when I went back and I started really thinking about the question of calories. And as I started to think about it more and more, the less and less sense the whole thing made. Calories in, calories out is true, but it's the lowest level of thinking that you can get and the least useful, because you're not actually getting to the root cause. It's the sort of lowest level, and you never get to that, what is really controlling that sort of calories in, calories out. And it's like, well, if you look at calories in, what's the main control? Well, it's like hunger, obviously, which is a hormonal issue. And what's the control of calories out? It's not exercise. It's mostly basal metabolic rate, which again is hormonally mediated. So everything works on hormones. And the main one, of course, is insulin, which is the one that I had been prescribing. We have a hypothesis that insulin causes obesity. So give insulin. Do you get fat? And the answer is yes. I was like, didn't you just answer the question? And the second part of that experiment, if X causes Y, take away X. Does Y go down? So take away insulin. Does obesity go away? And the answer is yes, it does. If I give insulin, do they get fat? Yes. If I take away insulin, do they get thin? And it's like, yes. Well, that's really all you need. Like the intermediary steps, whether it's calories, whether it's basal metabolic rate, whatever you want to do, this is a root cause analysis. And so I did try a low carbohydrate diet at first, and it was quite effective. I actually lost weight quite quickly. I mean, it was very interesting that it was actually way more effective than I thought it should be or would be. And, you know, my weight really came down a lot, and it's like, oh, this is really, really interesting, because this is actually what I've been looking for. And that's where I started to really blog about it. And I was looking back, it was like 2013, I started blogging about it and developing a program, which eventually became thefastingmethod.com, about low carbohydrate diets. And what was interesting was that I started with low carbohydrate diets. And my patient population is skewed because I'm a specialist. So mostly I had older patients, and in Toronto, mostly like ethnic population. So I could talk to them about low carb and this and that, but they didn't really understand what I was talking about. Like, you know, you'd say, oh, eat low carb, and then you see what they're eating. It's all rice and noodles. The point is that you don't have to necessarily go low carb, because there are other ways. What you need to do is lower insulin. And really, so that's when I was talking to somebody, and they're talking about doing cleanses and fasting. Is interesting because she had lost a lot of weight, and she said, you know, somebody had told her, one, eat lots of fat. And I thought, wow, that's really strange, but it worked really well. And two, she did all these cleanses, which I thought, well, that's really stupid. That's just like fasting. And fasting is obviously bad for you, right? I thought it was terrible. That was my gut reaction, as was everybody else's when I started talking about it. And then I thought, okay, well, how does this work? Because what you're going to do is you're going to lower insulin. If you lower insulin, you know that you're going to you know, lower your blood sugars, which is good for type 2 diabetics. And after that, you're going to metabolize fat, because that's what body fat is. It's simply a store of your calories. And we know that insulin inhibits lipolysis, so that if insulin is high, you can't burn body fat. You don't want to. But if it falls, you are going to activate lipolysis. So that seems good as well. And so I'm like, everywhere I think about this, you know, it just seems good. Like the whole thing seems like exactly what you want to happen. Fasting is very simple. It's something that everybody sort of understands intuitively, as opposed to trying to say, eat this, but don't eat that. So that's hard when you're dealing with a 70-year-old Filipino woman who's eaten the same thing for the last 70 years, right? You simply say, don't eat anything until dinner time, and no snacks and no fruit and nothing. So it's a lot easier because it's a lot simpler. And so I started using it. And then it was like, some of the cases we saw were just incredible. Like, so we published a case series in BMJ, the British Medical Journal, case reports. And so we had 3 patients who had about 20 years each of type 2 diabetes, about 5 years on exogenous insulin. And we started them on a fasting regimen, which wasn't too extreme, like 24 hours of fasting 3 times a week. That is, eat once a day on 3 days of the week. And with between 5 and 18 days, all 3 of them had come off all their insulin. And it's like, whoa, they were on high doses of insulin. And within a month, we basically got them off all their insulin. Within 2 months, I think all were essentially non-diabetic after 20 years of diabetes. Well, we advised them to stay away from sugar and some of the sort of, you know, some of that stuff, right? Eat whole foods and that kind of standard sort of stuff. But, you know, nevertheless, it was such an incredible response. And the thing about that was that diabetes is a huge risk factor for heart disease, stroke, and cancer. Those are the major killers of Americans. I have nothing against like ketogenic diets, low carbohydrate diets, but there's no reason why you couldn't implement them at the same time. And there's no reason why you can work these together, because it's a much better solution than just changing the diet, because you're changing both the diet, the what it is you're eating, but also the when it is you're eating. So even if you eat low carb, if you're eating constantly, I think you're only getting half the benefit. Well, on the one hand, they knew me, so they knew I wasn't crazy. But there was a lot of skepticism. The dietitians thought I was completely insane and wouldn't sign off on it like whatsoever. In fact, our clinic, we had to not involve the hospital at all. I tried to get a dietitian originally, so I worked with Megan Ramos, and then again did it herself and wound up, you know, thinking, wow, this works really well. So it's very interesting because so my colleagues sort of were skeptical. You know, I gave presentations at the hospital and so on about what fasting does, the physiology, and why it should be so beneficial. And then slowly what happened was that because we share a lot of patients, some of these cases were like just unbelievable. Like, so they started seeing people losing tons of weight, or people just coming off all their medications, all their insulin, and so when they saw it for themselves, they were like, whoa, what happened here? And the other thing that is that a lot of the doctors sort of understood the physiology, and that understood that there was nothing wrong with what we were doing. And most of them would say, hey, I used to do that in residency. So, and I was like 30 pounds lighter back then. So a lot of them just saw the truth of it sort of instantly. So in my area anyway, it very quickly became, okay, sort of within a year or two, it was like, okay, well, this makes a lot of sense, right? But it's still not, because I'm not like a university person, and it's still not widespread, and there's still a lot of this sort of academic inertia to sort of overcome, just like this whole calorie story. It's like, it's not a new story, but boy, do they like to hang on to that story. So in the transition from sort of the fed state to the fasted state, you go from, say, and this is from Cahill's data, up to about 24 hours. If you have a relatively high carbohydrate diet, you're going to have enough glycogen to take. So glycogen is chains of glucose that is in your liver. So your liver just takes the glycogen, chops off the glucose, and sends it out into the blood. And so you're still metabolizing glucose. Fat is a triglyceride, and it's totally different. So it's 3 fatty acid chains with a glycerol. So the glycerol gets converted into glucose, but yeah, your body mostly metabolizes the fatty acid chains, not glucose. It's a totally different source of energy. It's sort of like, electricity versus gas. They're both forms of energy, but they're totally different. And it's the same with fat and glucose. In between when fat metabolism ramps up, there's this period from about, say, 24 to 30 hours where you're actually breaking down some protein in order to provide glucose, because your fat metabolism hasn't ramped up sufficiently yet. And that's where people kept saying, well, look, you're burning muscle, you're burning muscle. It's like, no, you're burning protein, which is not the same as muscle. And this is very important because your body has excess, or an obese person has excess, not just fat, but excess protein as well, because you got the skin and you got the connective tissue and all that structural stuff, which is not fat. And this is one of the reasons, and this is a clinical observation, so I don't have any data to back it up. But we've treated, thousands of people, and some have lost hundreds of pounds, and we've not referred anybody for skin removal surgery, because we tend to use a lot of fasting. And during fasting, you actually want that period of burning this excess protein, which is connective tissue and skin, because your body, remember, replenishes skin every few days. Skin cells get replaced. But if you're not eating, your body doesn't want to replace those skin cells. So it's going to metabolize them. So this is the same thing you see in prisoners of war from Japan. There's no excess skin flapping off of them, right? Even if they lost 50, 80 pounds, because they've metabolized that protein for energy.
When you read the history of the research, we've always known that about 25 to 30, 35% of the excess weight is lean tissue to accommodate, carry the fat tissue. So something has to decide whether the excess calories are going to go to fat tissue or lean tissue, which tells you right there that the accumulation of both has got to be hormonally regulated, right? Because it's not just, if you're assuming that the fat tissue got fat because you just dumped excess calories into it, then what prompted the lean tissue to be built up along with it?
The recent data from some of the intermittent fasting studies show that you don't get an increase in muscle loss. It tends to actually be preserved better. And again, one of the things that we know is that when you don't eat, there's a predictable sort of change in hormones. That is, not only do you see insulin fall, but you get this other hormones that go up. And one of them is growth hormone. So growth hormone is going to bump up, which is going to help you preserve lean tissue, because in a state of growth hormone deficiency, for example, we know in men that you can replace it and you'll get more muscle growth and all this sort of stuff. So that increase in growth hormone may help preserve that sort of muscle while sort of still losing all the skin and connective tissue that you want.
There were 50 people sitting around a big round table, and I took a poll of how many people were doing intermittent fasting along with very low carbohydrate diets, and it was 45 out of 50.
Wow.
Which was, at least in our world, I think one of the things we think is it's much easier to do.
Yeah.
Than doing low carb, because you're not hungry all the time. So skipping a meal, skipping 2 meals is relatively easy.
Yeah, I think so, because if you're eating a lot of protein and fat, again, and this is why I think the calories thing is so stupid, like honestly, is that you completely ignore the fact that when you eat protein and fat, there are, again, well-known hormones that get activated, which are satiety hormones like peptide YY and cholecystokinin, and all these hormones which tell you to stop eating. And it's like, okay, so if you're eating foods, protein and fat, that are telling you that you're full and don't want to eat more, well, that's a good thing. If you're eating a bagel with, jam or something, you don't activate those satiety signals. That's why at 10:30, you're looking for a low-fat muffin. Insulin plays like a huge role, like you wouldn't believe, in cancer. So cancer is the second leading cause of mortality in the United States. 2003, they looked at sort of obesity as a risk factor for cancer. And lo and behold, it was a huge risk factor. In fact, it was the number 2 risk factor, like right after smoking. It dwarfed everything, like all that other stuff that we talk about for cancer, like, carcinogens and chemicals and this and that. It's why it was like, whoa, it was way, way up there. So now if you look at the WHO, they classify 13 types of cancer as obesity related, including breast and colorectal, which is sort of the number 2 cancer in number 2 and 3 cancers after lung cancer. And insulin, of course, plays a huge, huge, huge role in that, because obesity is really the state of hyperinsulinemia. And insulin, it turns out, is a massive growth factor, which is super interesting because, nobody knew this before. Yeah.
Because now that I've read the literature, you can see that insulin and insulin-like growth factor are both drivers of tumors, tumorigenesis, malignancy, and that this was at NIH, Derek Leroy. And he told me that he first published it because it was insulin. It was only published in diabetes journals. Insulin was something you talked about in the diabetes world. So when he realized that it was a cancer promoter and that cancer cells upregulated insulin receptors, it was about 15 years before he ever discussed that in a cancer research journal.
Yeah.
Because that's not what they published. That's not what they cared about. They cared about chemicals in the groundwater and genetics. And, it's just the way medicine works. And so it existed in this bubble.
Luke Cantley does all this work on PI3K, which it's then, oh, hey, here's the direct link between insulin, PI3K, and cell growth. So it's like, okay, well, this makes total sense now, because you got high insulin, which is a growth factor through PI3K, and it's like, oh, well, if stuff is going to grow, well, cancer is going to grow even faster, right? So there's like, whoa, that is such an interesting, link that, again, I didn't think about much, but is becoming sort of more and more obvious as we get later and later into this sort of obesity epidemic, which, again, to me, it's sort of like, it's not any more difficult than now we are facing diseases of too much insulin. So therefore, the treatment is lower that insulin. How are you going to do that? There are some drugs that do that now, but not many. But it's going to be a low carbohydrate diet. It's going to be intermittent fasting. So if you're talking about performance, then I think that like in season sort of peak performance, you don't necessarily want to be fasting, because these guys have a very, very high caloric sort of need. So fasting is going to make it very difficult to get that in season. When you're off season, you're trying to maximize sort of regeneration and sort of maintenance, and that's when you're going to do it. So if you're talking about, applying it, and this is where having sort of a deep understanding of the fasting physiology is that you can do 2 things. If you're a recreational athlete, then one of the things that we try to do is something called training in the fasted state, where you take advantage of these changes in hormones that you get with fasting. So if you fast for, say, 24 hours and then you work out, then what happens is, of course, you're training your body to use fat as a fuel, which is good if you're trying to burn fat. But you've also got an increase in catecholamines, which is this, so this is this counter-regulatory hormone change. You have this predictable lowering of insulin, but increasing sympathetic tone, which is your fight or flight response. So you've got noradrenaline going up and catecholamines going up. So that's going to make you able to work out harder, actually. And this is something that Georges St-Pierre, the mixed martial artist, talked about a lot when he was doing a lot of fasting. And he's one of these top-end athletes. He was saying that when he fasted, what he noticed was 2 things. One is that he was zoned in a lot more, and he could actually, he felt a lot stronger, and his mental concentration was a lot better, which is important in mixed martial arts. And the thing about it is, I always say, well, think about the hungry wolf versus the lion that just ate, right? Which one would you rather face? Well, you don't want to face that hungry wolf because he's keyed up, he's zoned in, and that's what you want to do when you do the training in the fasted state. So the increase in catecholamines is what you get in it. The second part of the fasting that's really beneficial for recreational level athletes is this increase in growth hormone, because after you fast and then you work out and then you eat, what you're going to do is you're just going to have all this growth hormone. So you're going to be able to repair faster. So you're going to be able to train harder and recover faster, which is a huge advantage. But if you're looking for peak performance, then it's difficult to do that sometimes. So some people will sort of just use low carb diets, or they'll use whatever. And you see more professional athletes doing low carb. And that's where low carb diets may be much more advantageous, because you're getting sort of 80% of the way there with fasting without actually fasting, because you need those calories. You know, this is what Tim Noakes talked about. You had this whole change from the 80s where it was all about energy drinks, sugar, and carb loading, and I used to do triathlon in my high school and early days. It's like, I remember eating huge plates of pasta the night before a race. And it was like,
when you go back in the history of carb loading, so it comes out of the Scandinavian cross-country skiing world. And until the 70s or 80s, it was basically you trained all year long on low carb. Okay, and then you carb loaded just the day before the race, but then that whole idea of carb loading for marathon runners got popular, and suddenly it's like, well, doing it the night before the race is good, doing it every day is surely better, and then you end up with, an obese environment.